This is a routine transconjunctival small incision cataract surgery done in a moderately hard cataract, maybe about grade 3, with a dense PSC. So let's just see how the surgery panned out. And here initially I am making my sclerocorneal tunnel. I don't have a bridal suture in place, and sometimes this can be difficult if the patient is slightly, if they keep tilting the head, then it becomes a little difficult to do this, but you can manage. So the key is to get a good hold of the tenons with your limbs forceps just behind your incision, and just get the initial plane correct and stick to that plane. To be very careful, look how I'm angling my blade when I go to one side. This is, if you try to keep it straight, more often than not you will be superficial. So once I've got the corneal valve, it's pretty easy to then carry on the incision. So once the incision is over, I put in my side port, enter the chamber, and put in some HPMC, and I'm going to fashion my on the larger side capsular excess with my bent 26 gauge needle. So make sure you get a larger excess. That's the key, I think, in SICS. Among other things, of course, your wound has to be pretty good as well. And once that's complete, I'm going to go ahead and open up my incision, and watch how I open. I'm only making forward movements essentially. So, and making sure I keep the cutting edge perpendicular to the incision. I then go ahead with my hydrodissection cannula. That's a good wave, and just I'm trying to get it out with my hydrodissection cannula itself. You can do it with 2 dialers as well. But that's, once I have got the equator out, you can just rotate it, pressurize the chamber with the same BSS, and watch how I get out the nucleus. I just hold on to the limbus with my limbs and give posterior scleral pressure, and keep moving my hydrodissection cannula backwards. See how neatly it comes out. That's very important, how you place your hydrodissection cannula, how you give the pressure. Sorry, it can be anything. It can be a visco cannula, it can be a dialer, it can be a hydrodissection cannula, it can be a vectus, whatever. But the position at which you put it is very important. So I am now removing all the cortex. I can already see that there is a dense plaque in the center. Okay, I'm not going to be worried about that right away. First take out all the free cortex. I'm trying to strip it, but that plaque is there to stay. So I'm trying to now polish the posterior capsule with the Simcoe itself. Around the plaque I can get out those cortical fibers, as you can see, but the plaque itself is just too stubborn. All this is unedited, completely unedited. Just take out that subincisional vitellic cortex. Again try to polish, but there's no way it's going to come out. And look what I do. I just pressurize the chamber with HPMC. I've moved on to a higher magnification, not necessary. This is just to show the viewer. Trying to just focus on that plaque. I've taken a bent, in fact it's the same bent 26 gauge needle I used for my capsulotomy. It's better that you make a new one, but I think my nurse just felt like giving me the older one. and see how it comes. Can you see the sheet? You can just strip it off. Sorry, it's little gone out of the field, but you can see that I've stripped off that entire membrane just with the 26 gauge needle. And I can go for the smaller bits, not necessary, but just to show you that it can be done. But always make sure you keep your capsule tight. I'm using only HPMC here, as I usually do. See how nicely it's come off. And here I'm getting a little bit of folds. That's because the visco has escaped. That's a little resistant. Don't try too much. I have again refilled. This is important. Don't try to do it in a shallow chamber. So most of it has come out. A little bit here and there. I think we should not persist. Having said that, I am persisting, but that's enough. So I then take my capsular excess forceps, the little attachment, I strip it off. You can see how neatly it comes off, and the other one as well. And actually this part is more dangerous. You can easily catch the capsule with your capsular excess forceps, so you have to be very careful. Now I do this sometimes. I polish it with the tip of my visco cannula also, so any few of the cells can come off. Putting some viscoelastic, and then I implant my single piece rigid PMMA lens. I'm trying to do it at one go, but the AC has shallowed a little bit. Can you see that? So definitely it's not in the bag. So cool. And then you can just, using a dialer, make sure you put the trailing haptic also within the bag. And then I take off the HPMC, put in my intracameral antibiotic, do the bounce test after hydration, and conclude. Thank you so much for watching.